Is Lisa Hagan. She's our State House intern from Boston University.
Fantastic.
Yeah, I'll
Okay.
take Jeff.
We have
Jill. Okay, hi.
Bob Whittick is our photographer. And we have Chris Scott, our enterprise editor.
Oh, good.
Okay, hi.
Yep.
Great.
Hi, I think we've met, haven't we?
Yeah, we have.
Yeah, how you doing?
Well, thank you very much for coming to the, about what is going to transpire in Massachusetts with the Affordable Care Act. And Alec was kind enough to send me the letter that was sent to Secretary Sebelius, and so I did read it. And I didn't realize that we were granted 5 of the 9 waivers already. I didn't know that. So.
Well, originally there was, under health reform, we used a series of 9 waivers, and the ACA, as you know, only allows for 4. One of those 4, tobacco, we use on a 1-to-1 scale. So while it's a waiver, there was really no rate changes associated with it. And as a part of what the advocacy through the administration and the governor that we had initially, through CMS, directly to Secretary Sebelius and directly to the president, asking for a waiver. There was a piece in the Affordable Care Act that, in effect, was a Massachusetts provision. You had to have a working exchange, which we were one of the only states that had a working exchange, and you had to have a proportion of your population already covered that was higher than what was envisioned under the Affordable Care Act. So I think this was, a Senator Kerry, add into the Affordable Care Act to give us some flexibility to be able to get the waiver that we got, which was to transition those rating factors out over the course of a 3-year to help mitigate any of this. They don't want that care done at Lowell General. It's a very high cost place. You want it done at a lower cost place. You're going to have home health and community aid workers really focusing on community health. You're going to have, enough scope and scale to be able to put that kind of system in place, to be able to take those kind of payments, because you're going to be at risk.
But isn't less competition bad? I mean, if you have just, 2 or 3 or 4
if you got
providers.
4 across the state, I would agree with you. That's problematic. And then who has the leverage at that point? One of the things, as a major payer, that being Mass Health, we're using payment systems to try to drive transformation in the system to move away from, paying people fee for service and paying for the total cost of care. We have a couple delivery system transformation initiatives across the Commonwealth with organizations so that they build some organizational muscle and capacity to move away from fee for service and actually care for the population.
Is this what's called global payments?
Global payments, absolutely right, Jim. Okay. And so that you're going to get paid, an amount per member per month, and if they need heart surgery and rehab, that comes out of that. If they're generally healthy and you see them annually for a screening mammogram, or once they get 50, screening colonoscopy, or their annual flu shots, the money would come out of that.
But here's the issue, and this has come up even when there was Saints Medical and Lowell General. Okay, the outcomes. All right, Lowell General and Saints could provide the same procedure as the Boston teaching hospitals for a lot less and have equal outcomes or better. Okay, and yet we still see the imbalance and reimbursements between the Boston hospitles.
That's their biggest beef up here.
And it just doesn't seem fair.
I've talked to Norm. Norm is a good friend of mine. I've known him from when I was on the Mass Hospital Association board. I think what you have to understand is we're one of the few. We're upside down here in the state. The vast majority of
That's
others.
encouraging.
Well, no. I mean it in this way. The vast majority of other states that are out there, you don't go to an academic tertiary organization for your primary care.
Yeah.
You don't. Here we, as the system has grown up over many years, obviously, you know, we have a place, you know, we have a time where, you know, well, if you're going to have a child, there's, you know, a few kind of name brand places where, you know, you want to go. That doesn't happen in other states. A healthcare system and not a rescue care system. We have a tremendous rescue care system that we've built up over time. We, you know, if you look at us as a country against other, you know, Western states in terms of healthcare, we don't do quite as well. We should be rightfully proud, particularly in Massachusetts, with the kind of organizations that we have. You know, certainly in Boston, but you know, the UMass system, the Bay State system, the academic medical centers, and the teaching organizations that we have. But we've built a system that isn't necessarily focused on health and prevention. It's really focused on, you know, great rescue care. You know, we can fix you, you know, if you have a heart attack. We can fix you if, you know, you've been a smoker, you're diabetic. We can fix most of those issues. But those things, by focusing on that kind of care, that's really expensive, you know, and that's catching, you know, the cost curve at the highest point in the cost curve versus trying to do something on the prevention and wellness side. So coming from the hospital side, you know, I think when we were talking about Chapter 58, we realized that we were paying for a lot of those costs anyways, whether it be through uncompensated care or free care. The hospitals were bearing a lot of the costs of providing that coverage, and we all felt, you know, as we went through the process, that it was going to be more important and better business for us to have some kind of coverage for those individuals, because we're paying for that cost anyways, and it gives us an opportunity to focus on preventative care instead of all of your primary care for a population being done in your emergency room, which is, you know, the most expensive place you can do primary care. No. State Universal Health Care is Chapter 58 in 2006. So that's where we covered everybody. Yeah. And then Chapter 224 is where it is called the cost containment one, where we focused on the creation of the Health Policy Commission. The governor, through the Department of Insurance, you know, reviews and has to approve all rates. Creation of a health planning council, where we have to come up with a state plan.
So right now you've got a trigger on rates, right? They can only go up so much per year.
So that's probably the keystone of the of Chapter 224, and you're absolutely right, Jim. That's, you know, rates can only go up at the state's GSP, gross state product, and then I think that's for 5 years, and then it has to be 0.5% below that number subsequent to that, and that, you know, that number, you know, with some estimates, you know, is close to $20 billion. You know, it's a really big number, and it's a focus where we have to go, where we have to do.
But is that being jeopardized by the implementation of the Affordable Care Act? I mean, we're seeing that the costs might spiral beyond that. I mean, is that what we're looking at?
The base rates went up a weighted average of 1.9%. You know, if we our medical inflation is higher than one, you know, and we're just now starting to see this, and we're starting to see it in some of the other states. Is, you know, a lot of what we were worried about was the what ifs that were going to happen as a part of the Affordable Care Act, but now we're starting to see some data coming out. So a 1.9% weighted average, significantly better than what everybody projected it was going to be. There's, you know, the concerns about everybody, you know, employers are going to be fleeing away from, you know, 30-hour employees, and they're seeing a big uptick in the number of part-time employees. We actually are in 13. More jobs were created by part-time employees in 13 than full-time. If you look at it on a yearly basis, you know, over the last 12 months, that number is reversed. There's more full-time jobs than there were part-time jobs. The part-time jobs that have been created have primarily been in the restaurant and the hospitality industry. The restaurant growth has been significantly higher than one would have projected, and I think that you're starting to see, as we're slowly coming out of the recession, people are going back to eat at restaurants. You know, the restaurants took a pounding, you know, in 08 and 09 and 10. and they're now starting to come back,
Your concern,
So,
is that
and-
you do have concerns.
Yeah.
Okay, and what do you, what is the state actually focused on right now to keep the costs contained?
Right.
And to keep everybody happy? We do have some of the highest healthcare costs in the nation. You've
And
got
therefore the world.
yeah, okay, and we should include them, I guess. But the unions have complained about the luxury tax. Even here in our company, I think the average benefit is around $16,000 a year. Okay, now we got high deductible plans; they're outrageous. But if people want to go with that, but I think it was $23,000 for the luxury tax. So I can see if this thing continues and costs aren't contained, you're going to have average Joes like us, poor journalists, right up against the ceiling, and then paying penalties. Or the company's going to be paying penalties, and what do they do then? Well, they just
I would
cut
have,
back.
a couple things that we're really trying to focus on. One is under the ACA, and one of the reasons it's good for Massachusetts is under what we did in Chapter 58, the universal health care coverage. We put together what was in effect a patchwork quilt of coverage in order to get people covered. Some of those plans that we put in place and the coverages that we had, we were paying 100% of the care for them. There was no federal matching funds on them. But we had a breast and cervical cancer waiver, we had an HIV waiver, we had the health safety net, we had a medical security plan, we had literally like 8 or 9 different programs that we tried to tuck everybody in to get them covered. Under the Affordable Care Act, that goes away. We're down to 4 plans in 2 entities, the Connector and Mass Health. It makes it actually significantly easier for the employers to have to deal with. And because of, we did a great job in Massachusetts. ACA actually helps us because we can now cover individuals that we didn't used to cover up to 133% of the federal poverty guideline. And that federal match is 90%. So we pay 10 cents on the dollar, the feds pay 90 cents on the dollar. This is that Medicaid expansion that a lot of states have decided. They're deciding whether to do them, or some states have decided not to do them. I will tell you, coming from a business perspective, if I could get someone to agree to pay for 90 cents on the dollar on something, for costs that I'm picking up, somebody is paying for that care, whether it be through the emergency department or other things, I think I would probably do that.
Hospitals.
And
I bet now they're down to maybe 35.
Well, there's 66 total hospitals, so they're probably, if you think about the teaching hospitals, I think there's probably 17 or so teaching hospitals, so 40 or so community hospitals.
Do you like what you're seeing with the massive consolidation? Partners seems to be just getting bigger and bigger. There was a story in the Globe a couple of weeks ago about how big is too big.
Right.
Stewart had a juggernaut for a while.
Fail, Chris.
Stewart had a
I've heard that
juggernaut,
before.
and it seems that Stewart's retrenched a little bit, or at least they're not still trying to acquire
To
hospitals.
acquire more.
Here in Lowell General just acquired Saints.
Saints.
So, how does the consolidation in the providing side of the industry complement, or does it not complement what you're trying to attain on the other side?
So it's a great question, and I would frame the question or the answer in the context of right now, the majority of the payments that go out to providers are all based on fee for service. You do something, I pay you for this. Click, pay, click, pay. One of the things that we're moving to, both because of the cost containment bill, the Chapter 224, and what we're seeing under the ACA, in order for us to move our system from this rescue care system to a healthcare system, we have to put, we're moving towards a payment system, we're calling it alternative payment methods, where we're providing reimbursement for the total cost of care. So that means, if you're seen in the physician office, it's covered. If you need a home health nurse, it's covered. If you need some supports in your home in order to not be rehospitalized, it's covered. It's really hard for having run a small community hospital for a long time, it's really hard for small community hospitals to have enough scope and scale to be partnered with a home health agency, to be partnered with a skilled nursing facility, and to be partnered with a rehab facility to really care for the care across the continuum. So I think that there is a balance, that we're not there yet in a lot of places. You know, you mentioned partners. You know, I don't know how big is too big, but I think you're going to see more of the consolidations, because as we change our payment systems, where we're providing, you know, where we're going to pay you X amount to provide care for the population of Lowell. We're paying Lowell General X amount for that. Lowell General is going to ensure that, you know, they have to have, you know, a primary care network,